Hi everyone, and welcome to the Cardiff Student Psychiatry Society session on substance misuse disorder and alcoholism. So just to start us off, a couple of content warnings. Understandably, this subject is going to touch on substance misuse and alcoholism and also some themes of addiction. If you need any help regarding any of these topics, please contact your personal tutor, Cardiff Student Support, or MyMedic. So the learning outcomes of today's session are to kind of discuss the definitions of substance misuse and alcoholism. We're going to look at a couple of examples of specific types of substance misuse and to recognize the symptoms and revise the management of both. So substance use disorders. What is substance misuse? So it's a pattern of use of drugs in which the user consumes the substance in amounts or with methods that are harmful to themselves or others. So one of the key kind of elements here is harm. The criteria for substance use dependence in the ICD-10 is 3 or more of the following criteria in the previous year. 1, a strong desire or sense of compulsion to take the substance. 2, difficulties in controlling substance taking behavior in terms of its onset, termination, or levels of use. 3, a physiological withdrawal state when the substance use has ceased or been reduced, as evidenced by the characteristic withdrawal symptoms from the substance or the use of the same or a closely related substance with the intention of relieving or avoiding withdrawal symptoms. 4, evidence of tolerance such as increased dose of the psychoactive substance are required in order to achieve effects originally produced by lower doses, so tolerance. And 5, progressive neglect of alternative pleasures or interests because of the psychoactive substance's use, increased amounts of time necessary to obtain and take the substance or to recover from its effects. And finally, 6, persistence with substance use despite clear evidence of overtly harmful consequences, such as harm to the liver through excessive drinking, depressive mood states consequent to heavy substance use, or substance-related impairment of cognitive functioning. Efforts should be made to determine that the user was actually or could be expected to be aware of the nature and extent of the harm. So according to the ICD-10, you need 3 or more of these in the last year to be qualified for substance use dependence. And use disorders include the use of pretty much most substances, including opioids, cocaine, amphetamines, cannabis, inhalants, hallucinogens, and anabolic steroids. So the risk factors in epidemiology. The United Nations Office on Drugs and Crime estimated that around 275 million people use drugs worldwide in 2020. Nearly 13% are estimated to suffer from a drug use disorder. And in the UK, 130,000 adults entered treatment for substance misuse from 2020 to 2021. As expected, cannabis remains the most commonly used drug globally, and interestingly, amphetamines are the second most commonly used. Although the use of opioids is less common, they still remain a major drugs of potential harm and health consequences. And most people who use drugs tend to be polydrug users who use more than one substance concurrently or sequentially. So, covering just a couple of substances that can be abused, we'll start with opioid misuse. So, some of the symptoms you might see in patients coming in with opioid misuse might be rhinorrhea, needle track marks, pinpoint pupils, drowsiness, watering eyes, and yawning. The first investigation you want to order for these people is a urine or saliva drug screen in order to identify the cause. And really importantly, the thing you need to know is the overdose emergency management is IV or IM naloxone. This obviously differs slightly to dependency, where the management is a referral to specialist drug dependence clinics or a specialist GP, who will probably start maintenance therapy or detoxification. Some of the first-line drugs used in detoxification can be methadone or buprenorphine, and compliance is often monitored through urinalysis. Obviously, there are physical complications of opioid misuse. These include viral infections from sharing needles, so any bloodborne infections like HIV, hepatitis B and C, they're more at risk of. Bacterial infections at the injection site. So they can develop things like infective endocarditis, septic arthritis, septicemia, and necrotizing fasciitis, venous thromboembolism, and respiratory depression and death. Onto cocaine misuse. So cocaine is an alkaloid derived from the coca plant and is a widely used as a recreational stimulant. Interestingly, the price of cocaine has fallen sharply in the past decade, which has resulted in cocaine toxicity becoming more and more of a frequent clinical problem. The mechanism of action of cocaine is that it blocks the uptake of dopamine, noradrenaline, and serotonin. Some of the effects you might see can be split into kind of 4 broad categories. The cardiovascular effects can be things like coronary artery spasm, leading to myocardial ischemia and infarction. Both tachycardia and bradycardia can be seen. Hypertension, QRS widening, and QT prolongation. Also, aortic dissection. Neurological effects we might see might be seizures, mydriasis, say that one, hypertonia, and hyperreflexia. The psychiatric effects are things like agitation, psychosis, and hallucinations. And then, other than these 3 main areas, we also see things like ischemic colitis if they ingest the cocaine. And this especially should be considered if the patient is complaining of abdominal pain or rectal bleeding. They also might present with hypothermia, metabolic acidosis, or rhabdomyolysis. So what can we do for these people? First off, the investigations you might want to order include urine toxicology, ECG due to the cardiovascular effects, a chest X-ray, a CT head, and an encephalogram. In terms of toxicity management, it generally just depends on what specific symptoms they're presenting with. So generally, benzodiazepines are used as first-line treatment for pretty much most of the cocaine-related problems. If they present specifically with chest pain, you might want to add on glyceryl trinitrate. And if a myocardial infarction develops from this, then you'll want to do PCI. If they also present with hypertension, then you might want to add sodium nitroprusside. Can't say that one either. The withdrawal syndrome with dangerous medical consequences do not occur after abrupt stimulant withdrawal. So luckily, these people won't have any really dangerous medical consequences associated if they do suddenly stop their cocaine use. In terms of management of dependency, we go for psychosocial interventions as our primary treatment, so things like individual or group drug counselling. For moderate to severe people with cocaine misuse, we might consider a more intensive outpatient therapy. And on a slightly different note, as it's not really misuse, another important one that can come up in exams is MDMA poisoning. So MDMA also is known as ecstasy, and some of the clinical features you might see in poisoning are neurological features like agitation, anxiety, confusion, and ataxia, cardiovascular effects like tachycardia and hypertension, hyponatremia, hyperthermia, and rhabdomyolysis. The management for these people is mostly supportive, but you can use dantrolene for hyperthermia if more simple measures fail. So as you can see, most of the management of toxicity and poisoning is mostly supportive. So onto alcohol use disorder. So alcohol use disorder refers to the misuse of alcohol, characterized by increased tolerance to the effects of alcohol, the presence of characteristic withdrawal signs and symptoms, and impaired control over the quantity and frequency of drinking. It's diagnosed when, over a 12-month period, the patient's drinking has caused clinically significant impairment or distress. It arises from a variety of genetic, psychosocial, and environmental factors. Hazardous drinking is another designation used to describe non-dependent problem use of alcohol. So alcohol use disorder does differ slightly from hazardous drinking. So hazardous drinking would be more of where someone is misusing alcohol, however, they are not dependent. So, symptoms and risk factors. Some of the symptoms of alcoholism include withdrawal, tolerance, as discussed previously, and also an increased or decreased liver size, jaundice, and ascites because of the toxic effects of alcohol on the liver. Features of withdrawal might include, so symptoms tend to start 6 to 12 hours after withdrawal, or after they stop drinking. And they may include sweating, tremor, tachycardia, and anxiety. Seizures peak at incidence at 36 hours, and delirium tremens, which can come up in exams, has a peak incidence at around 48 to 72 hours. And this includes symptoms like coarse tremor, confusion, delusions, hallucinations, fever, and tachycardia. So there are some strong and some weak risk factors for alcoholism. The strong risk factors include things like family history of alcoholism. So sons of men with alcohol use disorder are 4 to 7 times more likely to develop alcohol use disorder than sons of non-alcoholic fathers. The effect of family history in women is less well studied, but it also appears to lead to an increased risk of alcohol use disorders. Premorbid antisocial behavior has also been found to predict alcoholism, especially in subjects with early onset of alcoholism. And high trait anxiety strongly increases the risk of alcohol dependence. The presence of a social phobia or panic disorder is associated with a higher risk of developing an alcohol use disorder. So then weaker risk factors are lack of facial flushing on exposure to alcohol. So this gene for facial flush when they drink alcohol is common in some East Asian populations, and a less potent variant in terms of reduced acetaldehyde metabolizing capacity has also been found in some white populations. Low responsivity to alcohol, so also known as high tolerance, has been found to also predict the incidence of alcoholic outcome, so alcohol abuse and alcohol dependence. And it's hypothesized that individuals with a low response to alcohol consume more alcohol to feel its effects, and therefore are more likely to develop alcohol use disorder. The risks of alcoholism are increased in individuals after bariatric surgery to correct obesity. So a history of a gastric bypass might also actually be a weak risk factor. Alcohol consumption, alcohol problems, and alcohol abuse are all increased after have been shown to be increased after gastric bypass and vertical banded gastroplasty. Bit of a rogue one, I thought, but interesting nonetheless. So in terms of investigations, the first line investigations you'd want to do are a diagnostic interview using either the DSM-5 or the ICD-10 criteria, a validated questionnaire like audit, or the severity of alcohol dependence questionnaire, their alcohol level either through using breath and blood, and the Clinical Institute Withdrawal Assessment of Alcohol revised. Other investigations you could consider are CDT. So CDT utilizes alcohol inhibition of the transfer of sugars to glycoproteins. False positives can be found, however, in patients with liver cirrhosis, and CDT is less sensitive in women. But increased concentrations found in the serum are shown after regular excessive alcohol intake. So you could use CDT to assess someone's alcohol intake. Gamma GGT is closely correlated with alcohol consumption and can sometimes be used to monitor drinking behavior. However, unfortunately, these tests are not sensitive enough to detect abuse before it results in organic impairment. So yeah, you might see raised GGT, AST, or ALT in someone who's drinking excessive alcohol. Alcohol also has bone marrow suppressant effects, which might then result in a normal to low hemoglobin, HCT, and low platelets. And testing by liquid chromatography mass spectrometry can detect very small amounts of alcohol in the urine within several days of consumption. So you might see an elevated urine ethyl glucuronide in someone who's been drinking. And so in terms of management of alcoholism, Obviously, there are the three kind of areas of management. We've got medical, psychological, and social interventions. We obviously need an initial medical assessment and advice, especially as because of the toxic effects of alcohol on the liver. We might need to do detoxification and treatment of withdrawal. And this can either be done as an inpatient or an outpatient, depending on the severity of the alcoholism. And obviously, rehabilitation and aftercare are incredibly important to maintain abstinence from alcohol. So yeah, all of these interventions range from less intensive, so things like brief advice and self-help programs, to more intensive things like inpatient detoxification and rehabilitation programs, depending on the severity of the problem. Treatment goals also range from anything from total abstinence or just a reduction in the harmful alcohol use. So depending on what the person feels would be best for them in the long term, they may aim for total abstinence if they feel like drinking again would lead to another relapse in their symptoms and their problems. And so in terms of management of acute withdrawal, complex withdrawals may require admission to hospital for monitoring. And in this case, we'd use first line things like long-acting benzodiazepines, so like chlorodiazepoxide or diazepam. And additionally, you can use things like lorazepam in hepatic failure and carbamazepine as second line. So yeah, detoxification may or may not be necessary depending on the severity of the dependence, but a medical assessment and advice are always required. So just as some test our knowledge, here are some cases to go through. So case one is a 31-year-old woman who is an IV heroin user who comes to see you at your GP practice. Which of the following complications is she most at risk of due to her drug abuse? So I'll give you 10 seconds to answer this one. So the correct answer here is VTE, as shown on the slides earlier. Second case, a 58-year-old man is admitted with pneumonia. He drinks 20 units of alcohol per day and his liver function is normal. Approximately 12 hours into his admission, he becomes unwell. His observations are as shown below. His respiratory rate is 18 breaths per minute, oxygen saturations of 96%, blood pressure of 123/76, heart rate of 106 beats per minute, and a capillary blood glucose of 4.1. An ECG shows a sinus tachycardia at rate of 103 beats per minute, and on examination, he appears tremulous and sweaty and complains of feeling anxious. What is the most appropriate management? I'll give you another 10 seconds on this one. So the correct answer here is the chlordiazepoxide regimen and regular high-strength B vitamin replacement. So the patient is acutely withdrawing from alcohol and symptoms usually begin 12 hours following the cessation of alcohol intake. This patient will be undergoing assisted alcohol withdrawal in an inpatient setting, and as such will require prophylaxis of Wernicke's encephalopathy as well. The first one is not correct, as the patient isn't hypoglycemic. The second one is also not correct, as the patient will also require a benzodiazepine before the withdrawal. Bisoprolol is incorrect, as the patient is in sinus tachycardia due to the alcohol withdrawal, so the bisoprolol won't be treating the problem. And the lorazepam and IM B vitamin replacement is also incorrect, as lorazepam is only really used when there is evidence of alcoholic liver disease, and this person is documented to have normal LFTs. Also, a stat dose would not be sufficient to treat his alcohol withdrawal, and he will require a weaning regimen. So that's why B is correct. Okay, so case 3. A 60-year-old woman is admitted to hospital with alcoholic liver disease. She drinks 85 units per week. And the question is, when is the peak incidence of delirium tremens following alcohol withdrawal? So the correct answer here is 72 hours. So in terms of alcohol withdrawal symptoms in general, that normally occurs after 6 to 12 hours. Seizures normally occur at around 36, and delirium tremens around 72 hours. Case 4. A 22-year-old female attends A&E, explaining that her and her friends were partying and took some ecstasy. She has accidentally taken 5 pills over the course of the night. Which of the following symptoms might she present with? So the correct answer here is hypertension. So she's got MDMA poisoning. The symptoms we discussed earlier were neurological ones like agitation, anxiety, confusion, and ataxia. In terms of cardiovascular, she might present with tachycardia or hypertension, which was the answer. She could present with hyponatremia rather than hyperthermia rather than hypo, and then rhabdomyolysis. So drowsiness isn't really seen either. And finally, case 5. A 34-year-old attends A&E with chest pain, tachycardia, and appears very agitated and aggressive. According to his friends, he's been repeatedly saying that people are out to get him. Given the probable cause, what is the best treatment? So this patient has been suffering from cocaine toxicity. And if he hadn't shown the symptom of chest pain, benzodiazepines would have been the correct answer. However, as he shows chest pain, you can add glycerol trinitrate. The nitroprusside is used if he has hypertension, which wasn't mentioned. And individual counselling is more used for dependency rather than toxicity. A PCI could be considered if he then started to show signs of ischemia, but at the moment he's just got chest pain. Obviously, you'd do an ECG and look for those signs. But on the current knowledge, we'd go with B. So thank you very much for coming. If anyone's got any questions they want answering, just send me an email on murray1@cardiff.ac.uk. Yeah, thank you for coming. Cheers.